How cool is this? Talking to an empty room, no mask required. Alright, so I wanted to go over a little bit of this stuff with you. This is going to be the final exam for RAD 211. I'm going to post this up. Anybody that wants to look at it can. You don't necessarily have to. So starting off, remember how the layers of the meninges are set up. You've got the pia mater, which is in contact with the neural tissue, and then you've got the arachnoid layer, which gives us a little space that we can inject contrast. And then on top of that, we've got the dura mater. That's the tough outer layer that protects the whole system. And ordinarily for myelography, we don't have the patient unconscious. The patient is either not sedated at all, or if they are sedated, it's very mild. And usually we just use local anesthetic. That's all we need for that. Remember your joint classifications. Your SC joint, for example, the sternoclavicular joint, that's considered a gliding joint. It's amphiarthrotic, it is slightly movable, but it's not the same as like your wrist or your fingers where you have total mobility. The joints in your back, those are amphiarthrotic. The joints in your skull, those are synarthrotic. Also in your pelvis. Remember, each half of your pelvis is actually 3 separate bones, the ilium, the ischium, and the pubis, but they're welded together with synarthrotic joints. Now, obviously, you can inject contrast into a synarthrotic joint. Whenever we're doing arthrography, we're always looking at synovial joints that are diarthrotic. Now, remember your contraindications and indications for arthrography and myelography. And what are the most common reasons why we do arthrograms? Shoulder arthrography, for example. The reason we do that is usually to investigate a possible rotator cuff tear. I mean, there's other reasons, but the rotator cuff tear is the most popular. And let's see what else we've got here. Okay, remember your positioning for cervical and lumbar myelography. Patient's got to be face down on the table, and we're going to inject contrast. We always inject contrast into the lumbar region, and then if we need that contrast to get up into the cervical spine, what do? Well, we tilt the table down so that the patient's head is down. We have shoulder pads to keep them from sliding off the end of the table. Let's see, synovial fluid. Contrast agents. Okay, remember for MRI examinations, we need to use MagnaVist or something comparable to that. But MagnaVist does not show up on an X-ray. So we need to mix that with something like Omnipaque or IsoView, something like that. That way we can see the contrast is in the correct space in the joint, and then when the patient gets over to MRI, MRI works like kind of the opposite from us. In MRI, iodine doesn't show up, so injecting iodine into a joint space won't do any good. You've got to inject something that's gadolinium based. There's several different name brands. The one I'm most familiar with is MagnaVist, but if you look on Google for contrasts used for MRI, there's a whole slew of the things. Oh, fun fact. Blueberry juice has enough magnesium that it can actually be used as a drinkable contrast agent, so you can do like like GI studies using blueberry juice. I thought that was kind of interesting whenever I found it out. What's on the end of your bones? On the end of your bones is something called Highline articular cartilage. If that stuff starts to wear down over time, then you have osteoarthritis. What if you have a disease process where the joint's being eaten from within because of an autoimmune disorder? Well, then that's rheumatoid arthritis. It's a different thing. I mean, they're both arthritis, but just different kinds of arthritis. Remember what the ligaments and tendons do. Ligaments attach bones together so that they can't move, but in a limited direction. So you can't take your knee and flop it forward. That doesn't work because the ligaments hold it in place. Tendons are different. Tendons are, they're made out of kind of the same material that the ligaments are, but the job of the tendon is to anchor a muscle to a bone. So it's like a transitional tissue there. Ligaments and tendons, very important. They don't show up on a regular x-ray. If we want to see them, we have to inject contrast, then they'll show up. Let me see. Spinal cord. Okay, remember your spinal cord only goes down to about T10, T11, something like that. Below that is called the cauda equina because it's just a bunch, I don't know how many, but I guess hundreds of nerve roots that go the rest of the way down. And on a myelogram, they look like a bunch of wispy little strings. Kind of interesting looking, actually. Where does the CSF come from? You remember that one from our little, not PowerPoint. Well, yeah, it was on PowerPoint, like in a couple of different places in myelography. But yesterday, whenever we were doing that game, there was a question about CSF and where it comes from. And let's see what else we've got here. Okay, in special procedures, not only are we imaging tissue, but we can actually fix it on the fly. So in interventional, as opposed to just plain diagnostic, we have the ability to repair the patient in addition to being able to see what's going on with them. And we can also take biopsy samples, stuff like that. And who do we need on hand for interventional radiography? Well, we need a radiologist or a PA at the very least, a radiologic PA. We need an x-ray tech, and then we need a nurse. Now, we may need more people than that, depending on how complicated the operation is, but at a bare minimum, you need those 3 people. And, okay, remember the equipment we need for interventional. We typically have a ceiling-mounted C-arm. Sometimes we have a biplane C-arm, which allows us to capture lateral and AP images simultaneously. The whole thing has to be set up so that we can have a sterile field. It's almost like an operating room, but with the addition of some highly specialized radiographic equipment. Remember, we need a small focal spot size. We need high heat loading capability. We need a high frequency generator. Those are all things that are going to be essential to our efforts. We also need a table, preferably one that we have like a joystick control of, so that we can move it precisely. Because remember, a lot of times the doctor's looking at really, really small blood vessels. So whenever we're moving the patient, we do it just a little bit at a time. Or we leave the patient still and just move the C-arm around them, depending on what we're trying to do. Let me see. Aortic aneurysms. The aorta, for whatever reason, I don't know why, but it seems like most of the time when somebody gets an aneurysm, it's down in their belly. It's going to be between the iliac bifurcation at the bottom part and the renal arteries at the top. So somewhere in that little area, that's the most popular place for an aneurysm. And it's, if it occurs in that area, we call it a AAA, an abdominal aortic aneurysm. And remember how the ductus arteriosus works? It's just up above your heart, and it's supposed to connect the pulmonary circulation to the systemic circulation by making a little hole between the pulmonary artery and the aorta. And in utero, that's great. But when the patient comes out of the mom and they start breathing on their own, then that hole is supposed to close up. If it doesn't, it can cause issues. And remember the line focus principle. Digital fluoroscopy, you know, what are the advantages of using digital fluoro? The main one is the ability to do real-time subtraction. That's worth its weight in gold. Absolutely. And automatic injector, not going to ask a whole lot about that, just kind of know how it works. It allows us to control the flow rate, the volume of contrast, the pressure. Let's see, flow rate. Oh yeah, the automatic injector is not sterile on the outside, but the inside of the syringe is considered sterile. So if there's any doubt that that thing has been contaminated, throw it away and start over. Now a little bit of legality. Now whenever we're doing these operations, we need to have informed consent from the patient. That means that we have told the patient what can go wrong. the advantages of having this procedure, the alternatives to having this procedure. What if we don't have an informed consent and we stick a needle in somebody anyway? Well, then that can be construed as battery. You know, you're not allowed to do that. What if I tie somebody up and won't let them go? Wrongful imprisonment. Okay, so go back over that legal stuff that we talked about in Unit 4. Let me see. Okay, from Unit 3, people that have like a lot of secretions, they have a lot of mucus production, sometimes the doctor will give them atropine prior to a procedure in order to help dry up some of that fluid so that they have a little bit easier time scoping out, like for a bronchoscopy. Now, what if somebody does have a history of allergic reactions to our contrast agent? Well, then we should probably pre-medicate that person with something like Benadryl, prednisone. That's pretty common. You know, they start taking that a day before the procedure, and that way if anything does go south, maybe it won't be too bad. A little bit of skeletal pathology and trauma pathology. Remember your different fractures, compression fractures, compound fractures, avulsion fractures. That's where there's like a little chip of bone taken out from a larger bone. An impacted fracture. Impacted fractures typically involve the humerus or the femur, and that's where there's been like a lot of force applied to the end of the long bone, and it's wound up driving it up into the head of that bone. Pretty nasty, but you know, really not all that common. What if somebody gets a bone infection? There's a name for that. And let's see. Remember the portal circulatory system. What does the portal circulatory system do? Well, it takes the venous blood that's returning from the intestines and filters it through the liver before putting it back in systemic circulation. This is your body's way of protecting itself against toxins that you might ingest. Let's see, ERCPs. Remember when you're doing an ERCP, when the doctor's in there, a lot of times they'll just go ahead and do what's called a sphincterotomy. They will cut into the papilla, the sphincter of Oddi, in order to release any fluids or stones that are backed up in there. And a lot of times that's really all they need to do. Once they make that incision and they release that sphincter, then all of a sudden, you know, all that old bile and stones and crud just comes pouring out of there, and the patient feels pretty much instant relief. Now, why do we do ERCPs? There has to be some reason why we do that. So go back and look at your indications for ERCP and the equipment that we use for ERCP, and what contrast can we use? Is it okay to use ionic contrast for an ERCP? Well, it turns out in most cases, yes, because the contrast agent's just going to go up into the bile ducts, and then it's just going to flow right back down into the GI system, you know, into the intestines, and it's perfectly fine for your patient to swallow iodinated contrast. We just don't want it to get loose into the circulatory system in any great amounts. And remember your needle gauges. Okay, like a 25 gauge needle is going to be much thinner than an 18 gauge needle, but it doesn't have the carrying capacity. So if I want to inject a lot of contrast quickly, then I need a needle with a lower gauge, like an 18 or maybe even a 16 gauge needle. That's going to give me the higher flow rate because it's got a larger diameter. Now a 25 or a 27 gauge needle is going to be more comfortable for the patient because it's a smaller needle and it disturbs less of the surrounding tissue. Less chance of bruising, you know, unless you're really ham-fisted about it. And don't forget your French numbers. Every French unit is equal to 1/3 of a millimeter. So if you have a catheter with that says it's a 7 French, okay, well, how big is that? Well, if you do your division, you know, you say, well, okay, I'm going to divvy this out. There's 3 French per millimeter. So if I've got 7 French, that means I've got 6, which is 2 millimeters, and then with 1 left over. So this is going to be 2 1/3 millimeter. Pretty easy. Heart circulation. Remember that the deoxygenated blood is in the right side of the heart and the oxygenated blood is in the left side of the heart. So when the pulmonary arteries are taking blood away from the heart, it's deoxygenated. It's coming from the right ventricle. And then once we've been out to the lungs and gotten refreshed and come back, then we're coming back via the pulmonary veins, and that blood is oxygenated. And coronary arteries only accept blood during diastole. The heart has to be relaxed in order for those vessels to accept blood. And that's just to keep them from getting blown out by the huge pressure when the heart beats. What is a myocardial infarction anyways? Hopefully you remember that one. Okay, is infarction and ischemia the same thing? Now, why do we do coronary angiography? Well, a lot of times people have something called atherosclerosis. They have plaques built up in their heart arteries, and so whenever we are looking at those coronary arteries, then we're investigating the presence of plaques and if the patient needs to have those things stented open. What if somebody has severe hypertension? Are they okay to go with angiocardiography? Probably not. Remember, angiocardiography is something different. Angiocardiography is looking at the inside of the heart, whereas coronary angiography is looking at the vessels on the outside of the heart. So make sure you understand those. And the flow of blood through the heart, from left to right, and it does there's two circuits, systemic circuit and then pulmonary circuit. And if you forget, there's a nice video on my channel about pulmonary issues, including circulation. And the three major branches that arise from the aortic arch are the left subclavian, left common carotid, and then the brachiocephalic. Now the brachiocephalic pretty much immediately bifurcates again into the right subclavian and the right common carotid. But just go back and look at the picture of the aortic arch and make sure you remember all of that. And oh yeah, the circle of Willis. Go back and look at your little map of the circle of Willis and be able to tell me, okay, if I ask you what are the parts of the circle of Willis? Well, anterior communicating artery, anterior cerebral arteries, posterior communicating arteries, those all are part of the circle of Willis. So go back and look at that diagram, and it's got a list there of the vessels that are involved, and be able to pick those out of a list. And why do we do cerebral angiography anyway? Well, a lot of times we're investigating an aneurysm. That's totally possible. But somebody could also have a blood clot stuck in their brain, and we might be able to fish that thing out and restore circulation. That would be a really good outcome for the patient. Carotid siphon. Okay, y'all all know that one. And remember that the left and the right vertebral arteries, thank you very much, the left and the right vertebral arteries come up through the transverse processes of the cervical vertebrae. There's like little holes there that these arteries pass through, and then they enter the posterior portion of the brain, and then they reunite to form the basilar artery. And the basilar artery sits right on top of that clivus. I know you guys remember that from your study of skull anatomy earlier in the program. Okay, now, whenever would I see the superior sagittal sinus? Well, that thing's only going to be visible during venous circulation. So if I inject my contrast, I have to wait for it to go up through the arteries, through the capillary beds, and then into the venous collection system, and all of a sudden the superior sagittal sinus and the inferior sagittal sinus, those will both light up. And then I can see exactly where they are and what shape they are and all that good stuff. Somebody did a presentation on, this is no baloney, it was really good. Somebody had a superior sagittal sinus that was actually outside the cranium. So it was like just under the skin where the blood was flowing back out. And I'm thinking to myself, if that person ever gets a bump on the head, then they're going to be done. I don't think that that would be a very good thing for the patient. Okay, now I've got a diagram here that shows the aorta, the common iliac, the external, internal, and then the femoral arteries. So be able to identify those. And then, let's see, last page. Okay, remember whenever you're doing trauma radiography, and I know we've told you about this over and over again, it doesn't really much matter if your patient's positioned exactly like the textbook says. After all, they're traumatized. So the main thing we want to do is get 2 images 90 degrees apart. If we can do that, we'll be golden. Okay, now, decubitus pictures. Sometimes if a patient they're not able to stand up, if the doctor's worried about fluid in the lungs, then we're going to roll them with that side down. If the doctor's worried about air in the lungs, like free air, then we're going to roll that side up. What if you get an order and it says, okay, we need a decubitus chest on this patient, but it doesn't say which side? Then how do you make that determination? Well, you might want to ask the ordering physician, hey doc, which side did you want on this patient? Were you looking at the right side or the left side? I need them both. Okay, we can do that. But if somebody's come in for a decubitus abdomen, then unless otherwise noted, we always do left side down. And I showed you guys a picture of that earlier. Let's see. Okay, remember your additive and subtractive pathologies. Osteopetrosis is a hardening of the bone. Anytime you see petrosis or sclerosis, that means hardening, that means additive pathology. You may need to kick up your technique just a little bit. Subtractive pathology, on the other hand, is destructive. Stuff like osteomalacia, osteoporosis, those things are destructive pathologies, and they might require a reduction in technique. Because a lot of these patients, if you take their x-ray, their bones look really wispy. So you might need to back off your technique just a touch so that you don't over-penetrate by accident. And okay, if we're going to show free air under the diaphragm, how can we do it? There's several different ways. Be sure you go back and look at those. And yeah, that basically is it. So, if you guys know all that stuff that I just was talking about, then you are going to do very, very well on the RAD 211 final. Or you can totally ignore this video and just take your chances. Wow, I look really old. All right, y'all, have a good weekend, and I will be seeing you back in class on Thursday, and we're going to have, it's going to be the full class period, the whole 2 hours. You guys can bring snacks if you want to, that'd be great. But yeah, we're just going to look at each other's work, and me and my fellow instructors are going to come around and grade it, and we'll have questions for you, so be prepared to answer those, and we should have a good old time, right? I'm going to have fun anyway, and after all, isn't that why we're here? Okay, have a good one. I'll talk to you later. Bye.